Welcome to Emergency Medicine 101. Hey everyone, today, we're diving into the world of electrocardiograms, or ECGs. Think of an ECG as a heart secret diary, a squiggly story of its electrical adventures. We'll meet the main characters, the P wave, the QRS complex, the T wave, and their mischievous friends, the intervals and segments. Each one whispers a clue about your heart's health, and we'll learn to listen closely. Before we dive into reading ECGs, we need to know a basic concept. The paper output speed. It is the rate at which the ECG machine prints out a trace. The standard output speed is 25 mm per second. At this speed, one small square equals 40 milliseconds or 0.04 seconds. So one large square equals 200 milliseconds. And 5 large squares equals 1 second. Now since that's covered, let's get started. Whenever you get an ECG, there are a few basic things we should look for. These are rhythm, rate, the cardiac axis, P wave, QRS complex and STT changes for diagnosing myocardial infarction. And lastly, we'll look for any arrhythmias. There are many more things to derive from ECGs, but we'll discuss it in upcoming videos. For now, let's start with rhythm. Rhythm can either be regular or irregular. Whereas irregular rhythm can be regularly irregular, as in some AV blocks. Or irregularly irregular, as in atrial fibrillation. So, how do we check for rhythm? For that, we'll look at the R waves, more specifically, the distance between adjacent R waves, called the RR interval. If the RR interval is constant throughout the ECG, we'll tell that the rhythm is regular. But in case if the RR interval is varying, or not constant, we'll call it irregular. Like in this case. We'll learn more about rhythm abnormalities in the future videos. Depending on whether the rhythm is regular or not, we can calculate the rate. If rhythm is regular, with a constant RR interval, we will use the formula 300 divided by the RR interval to find the rate. So if the RR interval is around 3 large squares, the rate will be 300 divided by 3, which is 100. Even though you do not need to find a precise rate, a quick observation can be helpful. That is, if the RR interval is around 3 to 5 large squares, the heart rate will be normal, around 60 to 100 beats per minute. Similarly, just by looking, if the RR interval is less than 3 large boxes, we can understand that there is tachycardia. If the RR interval is more than 6 boxes, we can tell there is bradycardia. What if there are no large boxes between two R waves? In such cases we use a different formula. We use 1500 divided by number of small squares, which will also give us an accurate reading. In case the rhythm was irregular, these formulas will not be useful. In such cases, we will look at the rhythm strip. The rhythm strip shows the ECG trace for 10 seconds, or 50 large squares. So when the rhythm is irregular, we will simply count the number of R waves in the rhythm strip and then multiply it by 6, that will give us the number beat per minute. We now know how to look for rhythm and rate. Next comes the cardiac axis. It is slightly complicated, so listen carefully. What is the cardiac axis? Normally we think that the electrical activity starts from the SA node, goes to the AV node, and to the ventricles, via the Purkinje fibers. But in actuality, SA node, along with sending the action potential to the AV node, sends depolarizing vectors in the atria, in all directions. The electrical activity is moving in all directions through the atria and ventricles during the cardiac cycle. The sum of these depolarization vectors gives us the cardiac axis. Normally the axis is between -30 degrees and 90 degrees. Why do we need to look for the axis? Let's take an example. Consider an athlete's heart. Due to the extreme training, he has developed left ventricular hypertrophy. Therefore the number of depolarization vectors in the left ventricle is more than that of a normal heart. This pushes the cardiac axis to the left side, which we call left axis deviation. Similarly, if there is RVH, we will get right axis deviation of the cardiac axis. How do we look for axis? To look for the cardiac axis we will look at two leads. Lead 1 and lead AVF. A positive wave in both lead 1 and AVF represents normal axis of the heart. A positive wave in lead 1, with a negative wave in lead AVF, represents left axis deviation. While a negative wave in lead 1, and a positive wave in lead AVF, shows right axis deviation. Left axis deviation is seen in left ventricular hypertrophy, left bundle branch block, inferior wall MI, left anterior fascicle block, while right axis deviation is seen in right ventricular hypertrophy, lateral wall MI, COPD, dextrocardia, and in normal pediatric ECGs. Let's do a quick revision by solving an ECG. Here, the rhythm is regular, since the RR interval is constant, at 4 large squares. The rate is 300 divided by 4, giving us a heart rate of 75. Both lead 1 and lead AVF are having positive R waves, which shows normal cardiac axis. Well, that was easy, right? Next we will look at the P wave. P wave represents atrial depolarization. The best wave morphology will be seen in lead 2 and lead V1. How should a normal P wave look like? P wave should be smooth. It should have a height less than 2.5 small squares in limb leads, and less than 1.5 small squares in chest leads. It should have a duration, or width of less than 120 milliseconds, that is 3 small boxes. Similar to cardiac axis, the P wave also has an axis. Normally it should be upright in leads 1 and 2, while being inverted in lead AVR. Normally atrial depolarization occurs from right to left. Therefore, the first 1/3 of the P wave corresponds to right atrial contraction, and the final 1/3 of the P wave shows the left atrial contractions. This is important to know because, in case of right atrial enlargement, the depolarization of right atria overlaps over that of left atria, producing an impulse with higher amplitude than normal. So in right atrial enlargement, the height of the P wave exceeds that of normal. It will be more than 2.5 small squares. This is called P pulmonale. While in case of left atrial enlargement, the total duration of atrial contraction is extending, because left atria needs more time to depolarize. Here, the P wave will be wider than 3 small squares. At time a notch develops at the peak of P wave, giving an appearance of the letter M. These are called P mitral. Along with the P wave, we will look at the PR interval. It is the duration, from start of P wave to the start of R wave. Normally it will be around 3 to 5 small squares. P wave and PR interval is important in diagnosing normal sinus rhythm. So what is normal sinus rhythm? It is the rhythm made by the SA node. By diagnosing NSR, we can tell that the impulse generation is from the SA node. In normal sinus rhythm, all P waves will have same morphology, with the normal P wave axis upright in leads 1 and 2, and inverted in lead AVR. All P waves will be followed by a QRS complex. This implies that atrial contraction is followed by ventricular contraction. And lastly, the PR interval is normal and constant. Now you know how to read the most common ECG rhythm. Lastly, in this video, we will learn how to diagnose myocardial infarction by looking at QRST changes. For that, we need to know how to identify ST elevations and ST depressions. Normally the PR segment and ST segment will be in the same line, the isoelectric line. When the ST segment is above the PR segment, we call it ST elevations. Similarly, when the ST segment is below the isoelectric line, we call it ST depressions. According to this, we can classify myocardial infarctions into ST elevation MI and non-ST elevation MI. In ST elevation MI, there is complete occlusion of the coronary artery, while in non-ST elevation MI, there are only partial occlusions. It is important to diagnose them correctly, because the treatment is different for both. In ST elevation MI, the treatment is thrombolytics and percutaneous interventions. While non-ST elevation MI is treated conservatively with heparin and antiplatelets. Now we need to know where to look for these ST elevations and depressions. For that we need to know what the contiguous leads are. So the contiguous leads are a set of leads that represent a wall of the heart, or more accurately the area of the heart supplied by an artery. When the artery gets blocked, the corresponding regions gets infarcted, and that will be represented in the corresponding contiguous leads. Let's look at what they are. The first contiguous leads are lead 2, 3, and AVF. These represent the inferior wall of the heart, supplied by the right coronary. Next comes lead 1 and AVL, representing the superior lateral wall, supplied by left circumflex artery. Coming to the chest leads. V1 and V2 represents the septum, while V3 and V4 represents the anterior wall. These are supplied by left anterior descending artery. And lastly V5 and V6 shows the lateral wall, supplied by left circumflex artery. So if we have ST elevations in leads 2, 3, and AVF, we call it inferior wall ST elevation MI. If it's in lead 1, AVL, V5, and V6, we call it lateral wall ST elevation MI. And ST elevations in V1 to V4 shows anteroseptal MI. So what about the posterior wall? To diagnose posterior wall MI, we need to know the concept of reciprocal change. Consider two leads, A and B. An impulse is starting from the center and moving towards lead A and back to the center. This creates a positive wave in lead A. This same movement will be represented by a negative wave in lead B, since the impulse is moving away from it. So whenever there are ST elevations in the posterior wall, we will see it as ST depressions in the anterior leads, which are V1 to V4. So, always suspect a posterior wall ST elevation MI when you see ST depressions in anterior leads. Okay, so, let's wrap up this video with one last concept. The concept of evolution of MI. These are serial ECG changes that take place as the MI progresses. Initially it starts with tall T waves called as the hyperacute T waves, following which ST segment elevation begins. It progresses to typical gravestone appearance. Slowly Q waves develop and T wave inversions begin. Once recanalized, the ST segment returns to normal, but a deep Q wave remains, representing evolved MI. That is it for today. Thank you for taking the time to listen to this video on basics of ECG. It is our hope that this knowledge can help you make a difference in an emergency situation. We will be back soon with more important topics. Until then, keep learning and stay safe.